I came here in 2005, and I interviewed that when I came to Ireland, I would focus on what I thought were kind of the important needs, and one is hepatitis C, and we'll talk a little bit about that, and also infections in pregnancy. And okay. And there was a pre-existing DOVE Clinic, which took care of kind of high-risk women. DOVE is a lovely name with a little white bird standing for danger of viral exposure. Kind of destroys that lovely picture. But anyway, taking care of a lot of the hepatitis B, hepatitis C, HIV, and I tried to kind of turn the clinic to expand it into more kind of an infections and pregnancy clinic, and focusing on what was already there, which was hepatitis B, hepatitis C, HIV, but also starting to look at other STIs that were in the population, syphilis, chlamydia, and other infections where we actually had to have a better understanding. And so looking at Ireland already had kind of pre-existing guidelines for what you should do in pregnancy, testing for syphilis, testing for hepatitis B, testing for HIV. There weren't any guidelines on what to do with chlamydia in pregnancy, not guidelines on what to do with hepatitis C in pregnancy, and also not a good understanding of how common was syphilis and other infections in pregnancy. So part of my goal then was to kind of to understand that better using the population we had at the Rotunda, which is a fairly small population, but you don't need big populations, you just need good data collection and good cooperative colleagues, which is the setting that I came to at the Rotunda. So we put together the DOVE database, originally with funding through Friends of Rotunda, and actually we're very lucky to get a person called Valerie Jackson to help put that together. And we've been able to collect clinical data as part of routine care, and we've been able to extract some of that data and then actually give some of the SHOs and the SBRs the ability then to take that data under the supervision of the consultants, myself, Dr. Coulter, Mae Vaughan, to be actually able to put together that data, analyze it, and to publish it. Which is good for them, and it's good for us, and it's good for the patients. And this was just one of the first looks in terms of how common these infections are. We never did that before, so just even having this data was quite important to put together. HIV, hepatitis B, hepatitis C, and syphilis. This was just one of the first looks over time from the beginning, just gone up to 2010. So having that data is quite important to see what the trends are. And also, if we're actually planning interventions and planning analysis, we need to know how many patients we have and how it's changing. So HIV is one of the first things that I'm personally interested. Before I came to Ireland, I was involved in a lot of prevention of mother-to-child transmission studies. And originally, if you didn't treat HIV-positive pregnant women, 25% of children became infected. And with combination therapy and triple therapy, you should have zero transmission, okay? If you have an undetectable viral load, you should have no transmission. And you should have an end to AIDS, but children are still being infected. So one of the questions is, why are they still becoming infected, okay? And one of the original studies that I was involved in as part of a study in America was looking at, it was ACTG 185, looking at undetectable viral load in the mother's blood at the time of delivery. And if you had an undetectable viral load, there was no transmission. So that's what we're shooting for, and that was kind of an important publication published in New England Journal in 1999. But here we are, 20 plus years, 15, 16 years later, we still have children being infected. So we know what works, but we don't know why it isn't working. So the question is, why do children still become infected? Is it inadequate pregnancy treatment? Is it adherence issues? Is it maybe because the changes in pregnancy, maybe you're not getting enough drug, maybe because there's changes in the drug levels in pregnancy as there's changes in the volume of distribution, et cetera, et cetera. So one of the first things that actually Sam Coulter-Smith asked me to do was just actually put together all the data that we had on HIV testing and treatment in the antenatal setting in 2005, 2006. We just put together our experience on 250 HIV-positive pregnant women who were treated with triple drug therapy or sometimes single therapy at the Rotunda. And basically we found that if you had 4 weeks of triple drug therapy, you didn't infect your babies. Now, of course, you want longer duration of therapy than that, but even women coming in late in pregnancy, if they got a minimum of 4 weeks of HIV therapy, took the therapy, none of the babies were infected. So that was important information from this original analysis. So we found no transmissions when women received at least 4 weeks of ARV therapy before delivery. So this was important. You'd like to do more than that. You'd like to treat them all the way through pregnancy, but that is the minimum. And if you do less than that, then probably you actually have to do, if you don't have an undetectable viral load, you need to start more interventions, elective cesarean section, triple drug therapy after delivery to the baby. So all of these guidelines that have been put together really are based on some of these and other observational data from the rest of the world. So how do you treat HIV in pregnancy? Ireland was one of the first countries to use triple drug therapy for pregnant women. We originally had a protease agent called ritonavir, and then we changed to Kaletra, and then we moved to atazanavir, and recently we've moved to Darunavir. They found out that when pregnant women get nalfinavir, 5 years after they stopped using it, it was published in a French publication, there was a lot of infected babies, despite the fact that moms were getting nalfinavir. So probably they weren't getting adequate levels of nalfinavir in pregnancy. And then they started using Kaletra, and the American studies showed you had to actually increase the dose of Kaletra in pregnancy. And then subsequently we've gone to atazanavir and Darunavir. So we actually started looking at therapeutic drug monitoring in pregnancy with our small but kind of very tight population of HIV-positive pregnant women at the Rotunda, with cooperation of the nurse midwives, with cooperation of the sisters in the wards, with the cooperation of the laboratory. And I'm just going to show you some of the data that we've got. The first publication we put together was therapeutic drug monitoring of lopinavir, ritonavir, which is Kaletra in pregnancy. And we actually found from this study, contrary to what the Americans found, is you didn't need to increase the level. So you just had to do standard treatment doses of lopinavir in pregnancy. And this was published in HIV Medicine. And the study was done in America in a big ACTG study with 5-6 different sites. The European study was done at Rotunda, just because it doesn't take big numbers, it just takes big hearts and cooperation, and sometimes very small budgets, okay? And then subsequently, the next drug that was started to be used was that we moved from using Kaletra to atazanavir. And we actually presented this at the 2012 at the AIDS conference in Glasgow, showing the data on atazanavir in pregnancy. And a lot of the people here are representing, the Rotunda experience, and we used Liverpool as our TDM site to do the analysis. So we were looking at TDM in pregnancy. Women had first trimester, second trimester, third trimester, and then postpartum TDM. And I'm actually not going to go through the data, but I'm just kind of showing you this was one of the slides that was published. But basically, we did the PK analysis, very good data, very good analysis, and it did show there were decreases in the drug levels throughout pregnancy, but still, none of the babies were infected, fortunately, but some of the women did have low drug levels. And I basically, based on that information, there is the option to go from 300 of atazanavir to 400 of atazanavir. But all this data kind of supported then the use of atazanavir, and also gave us some guidance clinically that if we were having problems in terms of the virus not being undetectable and that we weren't concerned about adherence, then we did have options to increase the drug level. And then the most recent study we've done is using the flavor of the month now, which is Darunavir in pregnancy, much more potent than atazanavir. So most of our women go on Darunavir. This was also, the one thing about the atazanavir in pregnancy study, just of note, at the AIDS conference in Glasgow, it was given the award of the conference, so quite good. So that's a good recognition of 3,000 clinicians at that conference. The Rotunda study got the Glasgow, conference award, £1,000, which doesn't go very far, but still, it was a good recognition of the work that everybody in this room and others have done. So Darunavir is the most recent drug, and Darunavir is much more potent. We enrolled 23 women in that study. We're in the process of writing it up for publication, and basically, Darunavir is probably the most potent drug. There are decreased levels in pregnancy, to some extent, but not significantly. And more importantly, we did studies looking at cord blood. So we got great cooperation from getting labor and delivery bloods, cord bloods, postpartum bloods, which is not easy to do, as you can imagine, because the last thing is in everybody's mind is actually getting a sample for this study. But it was done. And we actually showed good levels, 10% transmission of the drug from the mother to the baby. But that 10% was an important 10% because the levels were adequate then to actually inhibit the virus. So 90% inhibition of in vitro inhibition. So good studies to show that Darunavir is a potent drug. Now, in women who have previously been on treatment, we all, you actually need higher levels, and this and other studies have supported the use of twice daily dosing of Darunavir in women who are, who have maybe resistant virus. So this data has been important in terms of putting together guidelines in the UK, Ireland, and international in supporting that. One of the other complications of PIs was thought to be, kind of glucose intolerance. Pregnant women have glucose intolerance. Protease inhibitors cause glucose intolerance. One study in America showed 25% of HIV-positive women had glucose intolerance by the glucose intolerance tests. This study that we did in cooperation with the endocrinologists and the obstetrics gynecology people showed no difference. So we didn't reproduce that because people were concerned about giving PIs in pregnancy. But our study published in International Journal of STD and AIDS shows no difference. We then also looked, a lot of our women were defaulting, got up to the matter after delivery, and we've done some analysis looking at why women don't show up after delivery. And we found that basically if women keep on treatment, they follow up. If they stop treatment, they default, and then they come back sick. So new guidelines internationally in Ireland, if you start an HIV-positive pregnant woman on treatment, keep them on treatment after delivery. It's probably good for them, and it's good for them not coming back sick, and it's good for their babies who are uninfected to have a healthy mother. Just one additional study, our original funding for this project, the DOVE database came from hepatitis C funding, and like I said, we don't know how much hepatitis C there is in Ireland. So we actually get funding from Friends of Rotunda. Previously done selective screening. You only did a hepatitis C in a pregnant woman if they, had a history of drug use or other risk factors. So we just decided to test everybody for 1 year. And we got funding through the Friends of Rotunda because we don't know how much hepatitis C there is in Ireland. And we think it's all drug users, but maybe there's other populations that are at risk as well. So this study then was published in Irish Medical Journal 2013, Universal Antenatal Screening for Hepatitis C. And basically it shows that, about 2/3 of the women previously knew they were hepatitis C positive, but actually up to 27% had no history of having a risk factor of hepatitis C. So maybe we should be doing more testing for hepatitis C. Maybe hepatitis C should be part of standard antenatal care. Hepatitis B, standard of care is to give vaccine and immunoglobulin, but if you have a very high viral load, there's about 30% transmission still. So hepatitis B, immunoglobulin, and vaccine doesn't work all the time. So part of a program, we started developing a program with the hepatologist to give lamivudine in pregnancy towards the end of pregnancy as part of standard of care, because there was data to support that in the literature, and started women on lamivudine at 32 weeks of pregnant if they had a viral load greater than 20 million. And then this was published also in 2015 in European Journal of Clinical Microbiology and Infectious Disease, just showing the success of, you get the viral load down from 20 to 100 million down to sometimes undetectable 5,000, 10,000, and then the hepatitis B immunoglobulin and vaccine worked. And we actually followed up the babies as well, and only one baby was infected, and that was because of default from vaccination. So it just kind of gives us some information. So this information was kind of helpful to support us using this program, but also in terms of where the gaps are in the program as well. Chlamydia in pregnancy. There was a study done by a doctor. When I arrived, it was already been done by Dr. Cafferkey, and I actually helped with the analysis of that. And it basically showed if you screened women in pregnancy for chlamydia, and they did that for 1 year, asymptomatic screening. If you were Irish, less than 25 and single, you had about a 13% chance of carrying chlamydia, which is quite significant. We don't have guidelines on testing for chlamydia in pregnancy. Based on that, we implemented at Rotunda, if you're less than 25 and you're asymptomatic, test, because it's cost effective to do it in that situation. And we did the audit of that. That was done by one of the SHOs or SBRs here, Amy O'Higgins, and this has just recently been published in the Irish Medical Journal. And it's not as high as in all populations. It's not 15%, but it's 5%. So still supporting, because there are complications both to the mother and the baby if you don't test for chlamydia. So this was important information to sort things out. I had one of my SBRs look at our syphilis data. In the interest of time, I'll just summarize what we found. So what is the worth of these studies, really? Well, the worth of the studies is we're taking clinical data, we're giving opportunities to the junior doctors at the Rotunda, and we're actually giving opportunities to the patient as well. So we have a better understanding of strategies to prevent HIV in pregnancy and follow-up postpartum. We actually have support for the safety of the protease inhibitor HIV drugs in pregnancy. We have accurate data on the HCV and island populations from this Rotunda study, and there's now hepatitis C drugs that are available, and I think it supports the use of routine screening. We have data to support the use of antivirals in pregnancy to prevent hepatitis B, and we have guidance on who should be tested for chlamydia in pregnancy. So I think a lot has been achieved in a small hospital with a fairly small population, with a fairly small budget, and with a very cooperative, group of colleagues. So, thank you for your cooperation, and thank you for your time.